have Dr. Andreas Kronbichler from Innsbruck, Vienna, present to us today. Andreas is an assistant professor at Innsbruck in Vienna. He just returned, I found out. He was in Cambridge as a visiting researcher in Cambridge, UK, and he's just returned back like last week or something and back into clinical work. And his interest is mostly in autoimmune diseases. He's the chair-elect of the Immunonephrology Group for the European Renal Association, and they have put out some interesting guidelines. So without much ado, I'll pass it on to Andreas. Welcome.
Well, thank you very much for this kind invitation. And actually, it's the first international grand route I'm ever doing, so I'm really excited about that. And the second excitement is, of course, to talk about ANCA-associated vasculitis. So here are my disclosures, and it's important to point out that I'm in contact with ANCA-GN, which is distributing avacopan in North America regarding research projects. So on the agenda, I will focus very much on the most recent European rheumatology recommendations, where we actually participated as nephrologists as well. And I will focus on the 13 recommendations, excluding the four for EGPA, because patients with EGPA, as you know, rarely have kidney disease. We will, of course, and this is important if you talk about standard of care treatment in AAV, discuss plasma exchange or no plasma exchange, and of course, nowadays, discussions on avacopan. But clearly, and this is also very important, as patients are mainly dying due to significant infections within the first year of diagnosis, we will also discuss a bit on infections and then allude a bit over to cardiovascular morbidity and mortality. So the EULAR recommendations actually put together a couple of different recommendations, and one was, of course, when to perform a biopsy. And we came up with this statement here, which was unchanged to the previous recommendation from 2016, that a biopsy is strongly supportive of a diagnosis of vasculitis, and we recommend biopsies to assist in establishing a new diagnosis of AAV and for further evaluation of patients suspected of having relapsing vasculitis. You see a low level of evidence, a low strength of recommendation, but quite a high level of agreement. And clearly, my personal comment here is that a biopsy is not only helpful for diagnosis, but nowadays more so for prognosis of the patients. We have summarized the different classification or also prognostic scores, which might help to predict actually prognosis of your patient with AAV and underlying kidney disease. So the most commonly used one is the burden classification. This hasn't been actually established to be a prognostic marker, but it's simply classifying your patients based on the glomerular involvement of your patient. So for instance, if your patient has a biopsy with over 50% cellular crescents, this patient will have a crescentic class on his kidney biopsy. If a patient has over 50% globally sclerotic glomeruli, he will fall into the sclerotic class. And these are the patients, of course, with a very high burden of fibrosis and irreversible damage. The two scores, so the Mayo Clinic Renal Pathology Society chronicity score and the ANCA renal risk score, also called BRIC score, are more so looking into prognosis. And the BRIC score, for instance, incorporates not only histology, but also the renal function at the time of diagnosis, and here stratifying by either over 15 mils or below or equal to 15 mils. The Mayo classification score is purely based on chronic damage on kidney biopsies. If you look now on the burden classification and this subdivision into focal class, crescentic class, mixed class, and sclerotic class, and this was a study performed in 145 patients, you will see that those with focal class, so this is classified basically on high amount of normal glomeruli, those patients fare quite well. So they have a starting GFR of 50, and at 1 year they have 61 GFR. And as you can see, the risk to develop end-stage kidney disease is quite low. If you look now into crescentic class, you will see that the starting GFR is 18. And this is similar to those here in the sclerotic class. But clearly what you see at 1 year is that those patients have an increase in GFR of around 20 mils, while those in the sclerotic class don't have an increase. Looking at 1 year, if you have a mixed class, you have pretty much the similar GFR as in the crescentic class. And it's nowadays becoming apparent that both classes have a similar prognosis if you look at long-term renal outcome. Next up was ANCA testing, and this is of course also very important. And we came up with a statement that immunoassays or ELISAs should be used and IF shouldn't be used anymore to actually diagnose a patient with AAV. And you see a high level of evidence, high strength of recommendation, and a high internal agreement. This is based on several studies, and this is a review put together by people actually focusing on ELISA tests and immunoassays. And clearly what you see here on the left side is that if you perform a BR3 ANCA or MPO ANCA ELISA here in green, that your area under the curve is actually outperforming all the indirect immunofluorescence tests which have been used previously. If you have a patient with suspected AAV, as mentioned, you should perform either one of the immunoassays or a direct ELISA against BR3 ANCA or MPO ANCA. If you have a high suspicion of ANCA diagnosis and the assay comes back negative, they recommend here that you should use a second assay actually to establish a diagnosis of AAV. So this study just came out a couple of weeks ago, and I found that very interesting. This is a study looking at a positive ANCA test in a French hospital, and they found 288 patients with ANCA positivity, and they subdivided those patients into true ANCA vasculitis, then a group with ANCA positivity, but non-AAV autoimmune disorders here as classified as ANCA-AI, or patients with ANCA-O, which has been a group without autoimmune features. And importantly here is if you have a high titer of ANCA, this actually strengthens your suspicion that this patient has a true ANCA-associated vasculitis, while those patients either with other autoimmune disorders or those actually without autoimmune disorders have a lower titer of ANCA. So this is important to bear in mind in combination with other features such as, of course, CRP, which is also different. So what were the diagnoses in these cases? So there were some patients with vasculitis, such as giant cell arteritis, having ANCA positivity. Then, of course, what we know is that patients with inflammatory bowel disease, or also those with autoimmune hepatitis, for instance, have a high degree of ANCA positivity. Those with lupus, especially those with lupus nephritis, have ANCA positivity. But also, of course, those patients with infectious disorders, so for instance, endocarditis, can present with ANCA positivity. And I was, for instance, not aware that patients with myocardial infarction and or stroke have a positivity for ANCA in such a high percentage. Moving on to therapy, and this is, of course, of interest to all of us. In terms of induction of remission, we actually proposed that those patients with organ or life-threatening disease, that these patients should either receive rituximab or cyclophosphamide as a basis of their induction therapy. As you can see, high level of evidence and high level of agreement. If patients are presenting with a relapsing disease course, and I will show you some data about that in a minute, we found that rituximab should be our preferred agent. The problem is that most of the studies have studied rituximab in a setting where the GFR was well preserved, so over 15. And so my personal comment here is that if you have a patient with a lower GFR, you should consider maybe using a rituximab approach where you combine rituximab plus cyclophosphamide in the induction of remission, or you can also add a plasma exchange, as we will discuss further on. So if you have a patient with non-organ life-threatening GPA or MPA, we found that rituximab is actually the standard of care, and this is based on the results of the RAVE trial. We don't believe that methotrexate or mycophenolate mofetil are valuable alternatives to rituximab, just if patients have a contraindication or a failure towards rituximab. So as mentioned, the RAVE trial is basically the landmark trial in AAV, proposing that rituximab is non-inferior to cyclophosphamide. In brief, these patients received rituximab 4 doses on a weekly basis without further remission maintenance therapy, in comparison to cyclophosphamide followed by azathioprine, and in both arms, steroids were withdrawn after 5 months. The primary endpoint, as you can see here, 0 steroids plus absence of disease activity, that was reached in 63.6% in the rituximab group, in comparison to 53.1% in the cyclophosphamide azathioprine group. This was non-inferior. If you look at a allowance of a bit of a steroid, you can see that the trend was the same as if the patients didn't receive steroids at 5 months or 6 months. Long term, and this is a study actually looking at 18 months, 146 individuals out of 197 achieved a remission, and they were followed for another 12 months. And you can see that if you give your patient rituximab without maintenance therapy, almost 40% of these patients will have a relapse within 12 months. And the same is true likely even if patients have azathioprine as a maintenance therapy. On the right side, you can see that if you stratify your patients by ANCA serotype, so either MPO ANCA or BR3 ANCA, you see that the curves subdivide here, and you see that the patients with BR3 ANCA vasculitis are more likely to have a disease relapse during follow-up. Looking at BR3 ANCA in more detail, this was a sub-study published a couple of years ago, looking at 131 patients. So this is actually all the patients coming in with BR3 ANCA. That includes those with a new diagnosis and those with a relapsing disease. And you can see that at 6 months, the complete remission rate was higher when rituximab was used, but this faded actually at 18 months. If you then look and focus on patients with relapsing disease at baseline, and they could look here at 81 patients, you can see that the trend is actually maintained over 18 months. So those patients with relapsing disease coming into the trial, especially those with BR3 ANCA vasculitis, fare better when they receive rituximab, and thus we came up with the statement that rituximab is the preferred agent in relapsing disease. Looking at the kidney, and that's why we are here, 51 patients in each group came into the trial with a kidney disease. And you can see at first sight that this was not balanced. So the rituximab group had a starting eGFR of 41 in comparison to those with cyclophosphamide azathioprine, who started with an average 50 mils. But in both groups, you can see that during the follow-up period of 18 months that all of them had a significant, or most of them had a significant increase in GFR, and here in the rituximab group plus 9 mils, and those in the psych azathioprine group plus 7 milliliter. So you can say that rituximab is similarly effective in preserving kidney function in comparison to cyclophosphamide. So what about steroids? And steroids are, of course, a very important topic if we discuss ANCA vasculitis nowadays. So here we recommend basically the Bexivers regimen with a starting dose of 50 to 75 milligram prednisolone equivalent per day, depending on body weight. And we recommend a stepwise reduction in glucocorticoids and achieving a dose of 5 milligram per day by 4 to 5 months. High level of evidence, high level of agreement. I think, and this is a personal statement, that the RAVE trial approach, and also what we can hear later, the ADVOCATE trial approach, that you can stop steroids around 5 months. That's something I do in my clinical practice, and I think this is achievable if you use rituximab as induction therapy and then maintain your patient on rituximab. This is, as I said, based on the Bexivas trial, where patients in the reduced dose group of steroids were actually maintained on 5 milligrams of steroids. The same was true also in the higher dose glucocorticoid regimen. This is based on body weight, and you can see that there are 3 different brackets here. So below 50 kilogram, 50 to 75 kilogram, and over 75 kilogram per body weight. So further data on steroids, clearly we need to include the LOAS trial, which has been performed in Japan, and they include 69 patients here in the group with the reduced dose glucocorticoid plus rituximab 4 doses, and compared that with a high dose glucocorticoid plus rituximab regimen. The initial dose here in the reduced dose was 0.5 milligram per kilogram, and at 5 months, 0 milligram of steroids. This study is a bit criticized because people say that the starting eGFR was quite high, and these patients were mainly MPO ANCA positive and didn't have a very severe kidney disease. Nonetheless, it clearly shows that you can significantly reduce steroids by around 2.8 grams actually at 6 months, which is quite remarkable. And importantly, the remission rates of the patients were similar when you combine that or compare that to a higher dose glucocorticoid regimen with 71% versus 69.2%. But this is important if you look at treatment-related toxicity. Here, there's a clear benefit when you use a reduced dose glucocorticoid regimen with just 2.5 millimeters here in comparison to 26. So you can significantly reduce not only your rate of significant infections, but also basically patient satisfaction if you can reduce the cumulative steroid exposure. What about avacopan? And clearly this is one of the most striking agents we have now in our hands in renal medicine. And avacopan in combination with rituximab or cyclophosphamide may be considered for induction of remission in GPA or MPA as part of a strategy to substantially reduce exposure to glucocorticoids. So high level of evidence and a high level of agreement. I think that this is a very fascinating agent, and we know that the C5a receptor 1, which is tackled by avacopan, is not only expressed by neutrophils, but also by macrophages and monocytes, which are relevant actually infiltrating the kidney and causing the damage we see in ANCA vasculitis. So the first striking results came from this animal model from Chapel Hill group, showing that if you knock in a humanized C5a receptor 1 in this mouse model, and you give this animal CCX168, which nowadays we know is avacopan, you can actually reduce the hallmark of ANCA glomerulonephritis, that is cellular crescents, by around 90% in comparison to animals which only receive MPO ANCA. If you look on the right side, and this is even more striking, if you give these animals a higher dose of avacopan, as you can see here, you can dose-dependently reduce the occurrence of cellular crescents. And what this group showed is that you can also reduce hematuria and proteinuria in comparison to the control animals. The Advocate trial has been published around 2 years ago, and they focused on 2 different primary endpoints. The first one was 26 weeks, and here it was a non-inferiority, which they could show. So 72.3% reached the primary endpoint in the avacopan arm in comparison to 70.1% in the standard therapy arm. Then they looked at sustained remission at 52 weeks. Importantly, steroids were withdrawn around 5 months. So the patients in the standard group didn't have any steroids anymore. And if they were assigned to rituximab, they didn't have any immunosuppression beyond 6 months. But you can see if you use this approach that avacopan is actually significantly better than standard of care and achieves long-term remission more frequently in comparison to the placebo arm. So that actually led to the approval of avacopan. The data fascinating me personally the most are when you're looking at the kidney function. And we did this study a couple of weeks ago and looked at those patients actually coming into the trial with a GFR below 60 and summarized that in this table. You can see that there is a significantly higher increase in GFR at week 26 and 52 in comparison to the prednisone group. And if you further look into other CKD classes, such as GFR below 30, this becomes even more striking. So the difference here between the groups is 5.5 milliliter per minute. And if you look into the subgroup of patients with a eGFR below 20, you can see that this is a really striking difference. So plus 5.8 at week 26 and plus 8.4 at week 52. And this study has now been published in KI reports a couple of weeks ago. So there are emerging real-life data, and of course, people ask how or when should we use avacopan. I think it's, as shown, its eGFR recovery potential is very good, but also, of course, those patients who are not responding to the standard therapy are, of course, also patients we would actually consider giving avacopan. And this is a study from the Netherlands looking at these patients with ongoing active disease. And when you add avacopan in this scenario, all of these patients actually achieved remission. One of these patients here, patient number 5, actually relapsed and received another dose of avacopan and went into clinical remission again. And if you look at corticosteroid exposure in this cohort of what we would call refractory disease, then you can see that there is a significant reduction in steroid exposure in these cases. So what about plasma exchange? And we came up with 2 statements. So plasma exchange may be considered as part of therapy to induce remission in GPA or MPA for those with a serum creatinine over 300 micromoles per liter to do active GN. Level of evidence 1A, strength of recommendation B, and you can see the level of agreement is quite low and the lowest actually of the recommendations. Second statement, routine use of plasma exchange to treat alveolar hemorrhage in GPA and MPA is not recommended. Again, level of evidence 1B, level of agreement a bit higher. In my practice, plasma exchange is offered to those with a serum creatinine over 500, but discussed on an individual basis. And of course, to those having alveolar hemorrhage and ending up to require ICU treatment or have very low oxygen saturation. As you know, the Baxivas trial was the largest trial in ANCA vasculitis, including 704 patients and looking at a combined endpoint of end-stage kidney disease or death. And there was no significant difference in the primary endpoint at 2.9 years. So reaching this endpoint, if you didn't receive plasma exchange, your probability was 31% in comparison to 28.4% if patients received plasma exchange. It was a 2-by-2 factorial trial, and the second basically outcome was looking at a glucocorticoid regimen, as already mentioned before. And again, here there was no difference if you used reduced dose or standard dose of steroids when they analyzed the primary endpoint. Looking at secondary outcomes as well, and I just want to point out here the risk of serious infections in 1 year. You can see that there is an increased risk, but not significant if you use plasma exchange. But if you look at the glucocorticoid regimen, you can see that the risk of serious infection could be reduced by 31% if you used less corticosteroids in the management of your patients. Then this led to another meta-analysis of all the plasma exchange trials, and some of them dated back actually to years where the ANCA test was not even found. So 1980 was 5 years before the test reporting how to measure C-ANCA was even reported. So very old trials lumping together with the newer trials. So the MEPEX trial here, including 137 patients, and the Bexivas trial, including 704 patients. Here highlighted in green, of course, there's a lot of biases actually belonging to these older trials looking at plasma exchange. But lumping everything together, and this is important, looking at end-stage kidney disease at 1 year, here the group of patients over 300 micromoles, equivalent to 3.4 milligrams per deciliter, had a better outcome in comparison to the control group, but the number needed to treat to actually prevent one event of end-stage kidney disease at 1 year is roughly 24. If you look at over 500 micromoles, so equivalent to 5.7 milligram per deciliter, the number needed to treat is actually 6.9. So much more efficient, if you would like to say so. On the flip side, if you look at serious infections at 1 year, again, if you look at over 300 micromole here, the number needed to harm is 11.8. So I think if you look at the patient having a creatinine below 300 and 500, I guess this is actually a higher risk than I would actually consider the benefit the patient potentially have in terms of kidney function recovery. If you look at 500 micromoles here, the number needed to harm is pretty much equivalent to the number needed to treat up here. So this led to a rapid recommendation, putting patients into different brackets. So low risk here below 200 micromoles, and the risk of end-stage kidney disease at 1 year around 2.5, in comparison, for instance, to the high risk here with a high risk of developing end-stage kidney disease. So the authors are actually recommended not to perform plasma exchange in those two groups, so low or low to moderate, but there is a weak recommendation to perform plasma exchange in this risk group. If they actually looked at alveolar hemorrhage in general, again, there's a weak recommendation against performing plasma exchange. There has been a lot going on now after publication of Bexivas. So just as an example, this is a study published in JASN last year from the French vasculitis study group, looking at patient cohorts benefiting from plasma exchange. And one score is actually without renal biopsy, and you can see that those patients having significantly impaired kidney function with a creatinine over 600 actually get the highest points actually. And if you had a score of 2 or higher, there was a certain benefit of plasma exchange. When they added renal biopsies, and we have spoken about biopsies, you can see that different risk scores or, for instance, the Crescentic class in the burden classification adds to your points. And if you have 7 or higher score, you would have a benefit of plasma exchange. So what about alveolar hemorrhage? And this is just a poster presented last year. You see the pink line here, and these are patients with severe alveolar hemorrhage not having plasma exchange. And if you see the green line here, these are patients undergoing plasma exchange in this group with severe alveolar hemorrhage. There is a clear difference in the curve, but of course the numbers in these subgroups with only 31 patients with severe alveolar hemorrhage in Bexivas don't really rely that much, and so there is no significant difference, although there is a 50% risk reduction if you add plasma exchange in this cohort of patients. So Dr. Hiramat was a part of one of these great Twitter conversations, and Mike Walsh was part of the conversations, and he joined a bit late. But you can see that when actually an expert was actually referring to his experience and his experience with Bexivas, the scenarios actually became much more in favor of plasma exchange. For instance, here, so patients with a serum creatinine over 500, initially only 39%, and after that 53%. But striking to me was that most of us would actually perform plasma exchange if there is a significant pulmonary hemorrhage, and 80% said yes to plasma exchange in this scenario. So what about refractory disease? So there is no data, limited level of evidence, but we say that those patients need to be treated in centers of expertise, and you need to rule out secondary causes underlying your patient. There are a couple of different options, but I don't want to go into details here, but you can see some actually treatments used by our colleagues in oncology and hematology, such as daratumumab, and one very interesting substance, but I have no time here to go through, would be imlifidase in such patients. Moving on to maintenance of remission. So rituximab is a superstar here, and we would recommend treatment with rituximab in most scenarios. Methotrexate and azathioprine may be considered an alternative. Good level of evidence. I will show you some studies later on, and a high level of agreement here. So the groundbreaking study was published 2014 by the French Vasculitis Study Group, called MAINRIDGEN-1. So these patients received cyclophosphamide as an induction therapy, and then were randomized either to rituximab, as you can see here, 500 milligram, 2 doses initially, and then subsequent doses, and compared to azathioprine. You can see first sight that rituximab was outperforming azathioprine with a hazard ratio of 6.61, and so rituximab was superior to azathioprine in this study. If you look at the relapse rate, so major relapses in the rituximab group, only 5% in comparison to 29% in the azathioprine group. And importantly, the frequency of severe adverse events was balanced between both groups. So the second major study was just published recently, but comprised 2 phases. So this is just induction therapy, again, relapsing patients here, and then induction with rituximab and maintenance with rituximab. This is just the induction therapy phase, and you can see that out of 188 patients, 171 actually achieved remission, and investigators were asked here to use 2 different glucocorticoid regimens, and most actually have chosen the lower dose regimen. Looking at the maintenance phase, a similar trend as before could be observed. If you give your patient rituximab, you will see only a few of these patients are relapsing during a follow-up of 20 months. In comparison to the azathioprine group, where you can see relapses even on therapy. Important here, and this is an important takeaway, if you stop rituximab, you can see that your patients will start to relapse after a couple of weeks. And then actually the curve is pretty much equaling the curve you can see here when you treat a patient with azathioprine. Risk factors for relapse is one here, the treatment group. So rituximab, of course, better than azathioprine, as you can see here. But also if you look at severe relapses at baseline, those patients didn't have that many relapses. So our patient with kidney disease tend to have fewer relapses than those patients, for instance, having ENT manifestations or lung manifestations with a more crumbling disease and higher likelihood to present with disease relapses. Duration of therapy, and this is a bit controversial, we recommend that the therapy should be continued for 24 to 48 months, and this has a high level of evidence, high level of agreement. Longer duration of therapy should be considered in relapsing patients or those with an increased risk of relapse, but should be balanced against patient preferences and risk of continuing immunosuppression. So low level of evidence, low strength of recommendation here. So this statement is based on the results of MAINRIDGEN-3. So MAINRIDGEN-3 re-randomized patients actually randomized in MAINRIDGEN-2. We are coming back to MAINRIDGEN-2 in a second. So this was a study looking at a tailored administration of rituximab in comparison to a fixed regimen. So MAINRIDGEN-2 included 162 patients with AAV, and the tailored rituximab infusions could reduce the infusions to 3 in comparison to the fixed dose where patients received 5 doses. So 1.5 gram versus 2.5 gram here. At month 28, they were re-randomized to either receive more rituximab infusion fixed here or placebo. And if you look at the outcome, so this is looking at all relapses, those patients receiving further rituximab were of course prevented from relapses in comparison to those in the placebo arm. Again, a very strong hazard ratio of 7.5. If the authors looked at major relapse-free survival, again, there was a very significant trend. A very important risk factor for relapse in future is a negative to positive transition of your ANCA test. So in this case, 50% of the patients relapsed in the control group versus 15% who did not. And in the placebo group, 10 out of 25 patients with continuous BR3 ANCA positivity relapsed. Importantly, if you give your patient more rituximab and you are not in a pandemic situation, your risk of serious adverse events is balanced in comparison to the placebo arm. There is a recent very important study from the Mayo Clinic. It's a retrospective analysis looking only at MPO ANCA patients. And what they observed was if you have a patient with MPO ANCA negativity, so here all these patients in the black curve, you will see literally no relapses during follow-up, while those patients having actually a negative to positive transition, or those patients remaining MPO ANCA positive, those patients are at increased risk to relapse in all different treatment groups, so rituximab, cyclophosphamide, or also mycophenolate as used by the authors. So maintenance of remission, as mentioned before, main reason do, and we will come back to that, we don't recommend using ANCA and or CD19 B cell testing alone to judge if a patient should receive further rituximab or not. So main reason 2 was a small study including 162 patients, 181 to the individual tailored schedule and 81 to the fixed scheduled. And they redosed rituximab in those with an individual tailored strategy when the ANCA test reappeared after being negative, if there was a twofold increase in the titer, or patients actually recovered their CD19 B cells. And you see a non-significant difference in relapse rate, but clearly a difference of 7.4% is a clinically meaningful endpoint, and this study wasn't powered to pick up a significant difference. Immunomonitoring in patients with AAV receiving rituximab, we recommend measurement of serum immunoglobulin concentrations prior to each course of rituximab to detect secondary immunodeficiency. So secondary immunodeficiency is a huge problem in AAV, and you can see this is a study from the Cambridge cohort looking at secondary immunodeficiency across different entities, and most of these patients actually had AAV as a diagnosis, and you can see that the proportion of your patient will end up to have severe hypogammaglobulinemia, defined as an IgG below 3 gram per liter. So this is the evolvement of IgG, and you can see that most of the patients actually had a downsized trend, but some of them also recovered their IgG over time. There are some risk factors for either developing a more severe IgG or ending up to require immunoglobulin replacement therapy. This includes female sex, pre-rituximab cyclophosphamide, if you have a low IgG below 0 to 12 months, or you're still receiving steroids at 12 months. So these are your significant predictors here. Replacement therapy only in those having a severe hypogammaglobulinemia, and those patients presenting with a bunch of serious infections would need immunoglobulin replacement. Infections, so patients with AAV either receiving rituximab, cyclophosphamide, and or high doses of glucocorticoids, we recommend the use of DMP-SMX as prophylaxis against pneumocystis and other infections. So lower level of evidence because we don't have any trial data, but high level of agreement. And so this is a study I've done a couple of years ago looking at DMP-SMX use when rituximab was used. And you can see that severe infections, all kinds of infections, could be reduced by around 70% when DMP-SMX was added to the treatment regimen. More recently, we have looked at this in the RAVE trial, and found that 180 patients received DMP-SMX in comparison to 17 patients receiving other strategy. So most of the patients actually had a severe infection within the first 6 months. And you can see that if you use DMP-SMX in comparison to the other options, the risk of severe infections increases considerably if you don't use DMP-SMX. And that was true for rituximab-treated patients here in red, or those patients receiving cyclophosphamide followed by azathioprine here in blue. So this is basically a summary of the EULAR recommendations: induction of remission, active GPA, MPA, treatment either with GC, glucocorticoids, or avacopan, start rituximab or cyclophosphamide in those with a very severe disease. In those with a less severe disease, rituximab is preferred. In patients with RBGN, plasma exchange might be considered. And if patients achieve remission, you should follow on with maintenance of remission. And we would just give our patients further rituximab, either 24 months up to 48 months. And if these patients are relapsing, basically you just return to the remission induction strategy. So we recently summarized the different guidelines recommendations, and this is just a read I recommend because there are some differences in the KDIGO 2021 and also in the updated draft 2023 in comparison to our EULAR recommendations, and of course to the ACR Vasculitis Foundation one, which actually only included rheumatologists. So causes of death, early and later follow-up periods, and this is bringing me to the end, and this is cardiovascular morbidity. You can see that in the first year, infections are driving mortality in our patients with AAV, while afterwards cardiovascular disease is the main contributor to mortality in patients with AAV. So this is a very nice study looking at different cardiovascular events in a UK database from Natalie Conrad, and what she found is that if a patient has a diagnosis with vasculitis, they have an increased risk to develop cardiovascular events. So within the vasculitis group, there are a couple of different forms which only occur very localized, such as relapsing polychondritis, and those patients might not have that high of a cardiovascular event risk, but those patients with active AAV are probably somewhere here where patients with systemic sclerosis are. So we summarized a couple of years ago the risk of venous thromboembolism, and that's substantial. If you just look at these two studies here to the right, so these are patients mainly presenting with kidney disease, you can estimate that the risk of a patient is around 15%. And those events usually occur within the first couple of weeks, so when the patients still have active AAV. We were contributing to this very large study, including 2,869 patients worldwide. And again, if you look at venous thromboembolism, you will see that those patients having the more severe kidney function compromise have the highest risk of venous thromboembolism. But even if you have kidney function with an eGFR below 15 to 60, you have a high risk to develop venous thromboembolism. We then focused on cardiovascular events, same group of patients, a bit fewer patients here, looking at myocardial infarction and stroke. And you can see that not only classical risk factors, but pulmonary disease and especially kidney disease here was driving actually the risk of patients to develop myocardial infarction and stroke. And in contrast to those with venous thromboembolism, the risk is actually the greatest at around 18 months after initial diagnosis of your patient. And this brings me to the last slide, and this is summarizing the real-life evidence, how we treat our patients, and that was before the ESC guidelines and the KDIGO guidelines and so on were updated. So not as strict as actually LDL cholesterol goal, but if you look at a patient with a very high cardiovascular risk, you can see that none of these patients actually achieved their goal here. And this is something we need to consider. We need to treat our patients more aggressively in terms of cardiovascular risk management. So I'm concluding here. So I was sitting a couple of weeks ago here in the kitchen of my parents, and my cat was a bit annoyed by myself preparing this presentation. So I had to stop here. So to summarize, the EULA recommendations provide an evidence-based guidance how to manage AAV, including eGPA. In my opinion, there is still a place for plasma exchange in the management of very severe disease manifestations. Avacopan has, as I've shown you, a beneficial effect on eGFR and might be used in those patients with severe kidney disease, refractory disease, and those at high risk of steroid-induced complications. And of course, pay attention to infections and cardiovascular disease. More research is needed here. So I wanted to thank the group contributing to the EULA recommendations. So we were not all of us, but we were still friends after discussing plasma exchange in AAV, which took up, I think, 2 hours of the whole meeting. And a special thank to my mentor and friend, Professor David Jane. Thank you for your attention.
Thank you, Andreas. That was a wonderful overview of all the guidelines. I'm sure a lot of people have opinions, and we have some keen vasculitis people. And I'll start with a few questions already. Dr. Noel.
Thanks for that summary. It was excellent. I just want to clarify, as a nephrologist, most of the patients we would see, especially in the inpatient world, would be fairly advanced kidney disease at presentation, often with pulmonary hemorrhage. And in most of those recommendations kept saying Ritux or cyclophosphamide, but I just want to clarify, in significant renal disease at presentation, would you recommend induction with cyclophosphamide, even though the guidelines are saying Ritux or?
Yes, I would, I mentioned it briefly. I think you're completely right. So if you look at the RAVE trial, so they excluded patient with a creatinine over 4. And so we are left a bit without good knowledge if patients with rituximab and if patients with a very severe kidney disease at presentation would also have the same response to rituximab as seen for those actually having a better preserved kidney function. So I think you either treat these patients with cyclophosphamide, or what we have used frequently is a combination of rituximab and cyclophosphamide, which has no evidence base. There are a couple of observational data, but it allows you also to cut down on steroids quite significantly early on. So that's something you need to consider, I think, in such a patient, either cyclophosphamide or the combination.
And does oral versus IV matter in cyclo?
IV. We are only using IV in Europe, so oral is not has not been standard here since the publication of Cyclops, which has been published 15 years ago, roughly.
Thanks.
Thank you. I think there's a hand up in the conference room.
Okay. Hi, thank you very much. That was a great presentation and overview. I have a question and want to get your thoughts regarding avacopan and the GFR improvement that was seen in Advocate. You showed a slide there based on GFR. I was wondering if it's known whether that is simply reflective of avacopan having less relapses, and so perhaps you had patients that relapsed with worsened GFR, or did that improvement in GFR proceed when patients were relapsing? And also, is there any, do we know if that's in patients that had kind of more crescentic biopsy findings, because logically that would be the ones you'd expect it to work most on versus the more sclerotic who often have very impaired GFR when they present?
Well, excellent questions. Very, very important. If you look at the relapse data in the New England Journal, you see that the patients actually in the control group started to relapse even while on immunosuppression. And so it was not only after 6 months, but I don't have any idea if the GFR increase difference is really, just because these patients didn't have relapses or not. So there is no information about that. And so this is something, of course, everybody needs to look into that. regarding biopsies, so this is a critical thing. Around 160 patients, so around 50% had a kidney biopsy. And the issue was we as investigators had to report that. So there was, let's say, a written report, and the predefined actually questionnaire didn't really include what we want to know. And that is, as you mentioned, if these patients with a true crescentic presentation do still have a benefit of avacopan. I think the ones you have mentioned, the sclerotic ones, are, in my opinion, probably those who have the biggest benefit of avacopan. Because when you look at C3 glomerulonephritis and the trial, they have done the Accolade trial with repeat biopsies, you could see that avacopan, in the avacopan group, the fibrosis, sclerosis could actually be reversed a bit, which is quite spectacular. And it's also known that C5a receptor 1 is contributing to fibrosis. And this brings me to an important point. If you perform repeat biopsies in your patients with AAV, you will see a significant progression, even though you would say the patient has a remission from crescents to sclerosis. So we really need to do better here, because even though the creatinine is improving, you know that the histology is actually getting worse over time. And so I think avacopan needs to be, or we need to study that in more detail. This is something we also suggested to Amgen, but we are a bit stuck here, to be honest, and we still want to do it, to retrieve all these biopsies and look at that, and also look at GFR outcome, also incorporating, as you said, basically relapse data, of course, because that's most important.
And just to follow up, thank you for that. Do you see eventually avacopan a place in maintenance therapy? Because I guess some of the points you brought up there, and the fact that there was less relapse, and the animal data showing an essentially halting of the crescentic process, and if it's already happened, it might be too late sometimes, right?
Yeah, I think there needs to be a study, honestly. So I personally wouldn't give it beyond 12 months, but I would just continue giving rituximab to the patient, to be honest. I think there is no true benefit beyond 12 months in terms of GFR recovery of a single patient. So I think they need to do the maintenance therapy study and probably combine that with rituximab in comparison to rituximab alone to have a true comparator.
Thank you very much.
So before we get to Ayub's question, there is a question in the chat from Mark Canny. Mark is asking about your thoughts on the 4-monthly rituximab dosing in the rituximab trial. Is that something you've seen or practiced in maintenance therapy? I think locally we are still doing the fixed dosing schedule from Mainritz and.
Yeah, I think so. This was actually studied because people used to see that after 4 months, some patients actually had some form of disease recurrence, and that was the idea behind that. I think in the meantime we have learned that 6 monthly is very good, and personally I do 6 monthly, and I've not used 500 milligrams. I've used 1 gram so far, but I think we can use 500 milligrams, 1 gram. But I guess 6 monthly is good enough. I don't see a lot of patients relapsing between 4 and 6 months. It's sometimes that patients present between 4 and 6 months and say that disease activity is coming back, but you can't really measure that. So you don't see a CRP increase or ESR increase in such patients. It's more so the general fatigue is coming back sometimes. I don't think that we should treat these patients based on increase in fatigue per se.
Thank you. So there are a couple of questions, but let's get to Ayub first, and then we can go back to the conference room. Ayub, you're muted.
Thank you for an excellent talk. Any comments about treatment of ANCA vasculitis in pregnancy?
Oh, that's a difficult scenario. I think what we have learned, I mean, it's not approved, and I probably shouldn't say that, but I think real life data on rituximab use in pregnancy is not that bad. I guess if you need to escalate therapy, I would use rituximab alongside steroids. If it's a non-significant disease recurrence, you might stick to azathioprine and steroids, for instance. Or if it's very severe, you can always use, of course, plasma exchange or immunoadsorption, because that's kind of safe. But I wouldn't really have any issues to use rituximab in these scenarios after, talking to the patient.
Thank you.
Thank you. So let's go back to the conference room. I think they have more questions.
Yeah, thank you. That was great. If I have time, 2 quick questions. The first is low-dose corticosteroids with rituximab induction. And again, in our patient population with kind of low GFR, sicker patients, there was a bit of a hint in Pexivas that they did worse if they had just rituximab induction. And we've started to see that here now that low-dose corticosteroids have become routine. Again, do you recommend the Ritux plus cyclophosphamide, or do you recommend higher dose steroids in people that are sicker? Have you seen that trend as well?
Yeah, we are in Cambridge. We had plenty of patients, and most of them are quite sick. So we have really adopted. I mean, we're a very strong plasma exchange center. So we have used plasma exchange, the combination rituximab, plus then very low dose steroids, so 20 milligrams sometimes. Initially 60 milligrams or pulses, and then after 1 week down to 20 milligram. And that worked quite well. But of course, there is no evidence for that. I know what you're referring to, that this patient cohort in Pexivas had, I think, a risk ratio of 1.8 or something like that. And I think this is something we need to keep in mind. If we use rituximab in those with very severe disease, we probably need initially more steroids to control the disease. I don't know why, or if this can be replicated at some point, but it seems that these patients need a bit more steroids.
And the other question is just maybe to get a little bit of insight into that 2-hour discussion that you had about the plasma exchange. We don't, as nephrologists, control our plasma exchange here, and often butt heads with our apheresis physicians about when it's indicated. And I know what the meta-analysis shows, but those 2 very large trials, which comprise, 80% of the patient population there, both had suggested, well, maybe you do see a slightly improvement early. When you look at the 1-year and 3-year outcomes, it really doesn't affect long-term function. And so I guess the question is, despite the evidence, people are now saying, go back to plasma exchange. And are we missing something, or do we need to do a different study? Because, there weren't really... There isn't really evidence to back that up right now. And again, I'm only talking because I need to convince our plasma exchange physicians that we should be doing this.
Yeah, that's a very good point. I think you're completely right in this. I'm also not that, how should I say, happy that, these meta-analyses include these very old studies. But when they just focused on MEPEX and Pexivas, the trend was the same, and I think it was even significant. And MEPEX clearly included the most severe patients, and you saw this, trend, a significant trend at 3 and 12 months, that you can prevent ESKD. But the MEPEX has also treated the patients with oral cyclophosphamide and in a very high dose and high doses of steroids. So what you also saw, that these patients are dying then. So that's another issue, of course. And I personally think there will be no more studies here because there will be no funding for a larger study. What we need to do now is to look at all these sub-analysis. So we are working on a couple of projects right now. And I think one of the things is to look at GFR recovery. And if plasma exchange is helping here, I'm not that, happy about looking at outcomes at 3 years, because when you look at Bexivas, so they stopped basically, or some patients after 1 year of follow-up. So at 3 years, I don't think that the numbers are accurate enough to say, well, after 3 years, we don't see this effect anymore. I think it's just because you don't have 1,000 patients anymore. You probably have 600, 500. We don't know so far. And I think this is a big issue, because then everybody says, well, there is no long-term effect. But this is, we can't really say that from this data. And B, I think even if a patient is off dialysis for, let's say, 1 year or 1.5 years, that's an important takeaway. And I think this is very important outcome.
Thank you. I think it's just past 9. I don't want to keep Andreas for longer. I think we can talk about Plex for another hour here as well, because this is a topic of great emotion and opinions. But thank you again, Dr. Kronbichler, for your excellent presentation and for a thorough overview of the EULAR guidelines with with the evidence backing it up and your personal recommendations. For viewers who, we will be recording and putting this up on our YouTube channel, and hopefully, we'll meet in person sometime.
Yeah, I hope so too. Yeah. See you soon.
See you.
Thank you.
Bye.